If you walked into a public health facility in Kenya today with TB, the government would probably tell you that treatment is free. And technically, that's true. Drugs are free and some diagnostic tests are free, but free care isn't really free, and it could get worse.
A groundbreaking 2026 modeling study published in the Public Library of Science has just sounded a massive alarm. It simulated what happens if international donors who've quietly paid for Kenya's TB safety nets for decades pull back their funding. In the worst-case scenario, this funding cliff dumps a staggering $80 billion burden directly onto the backs of patients, hitting the poorest households the hardest. To understand what this looks like for ordinary families, I went to Kibera, Nairobi's vast informal settlement. Immaculate at Siaya makes her home here. She washes clothes to feed her 3 children, bringing in about 3,000 shillings a week. Her youngest, a 6-year-old boy, has a severe drug-resistant form of TB. The drugs he needs are free, but because they're so toxic, his kidneys and heart have to be monitored every single month for 9 months.
ECG inafanywa Monday, ana review vile anaendelea akoaje, anaandika kwa book. So hiyo siku anapimwa damu. Wakishapimwa damu sio anamuexamine. Alafu sasa huwa unatumwa ECG fanye. So unaangalianga osigani ko best na wewe na mfuko wako pia. Ukienda kama Coptic ECG ni 3500. Na Kenyatta ni 2500. Ya na lazima ubook. Sasa tunaenda unasema tu ECG nafanywa leo, lazima ubook.
Challenge yenye iko ni mostly nutrition, kupata lishe bora ni ngumu. Yes, anapatiwa hizo 9,000 from the source mali natoka, I'm not sure ni wapi, but unapata imechelewa, na hata ukipiga hesabu hiyo ni 9,000 imepatiwa mtoto mmoja kwa na familia ni mama watoto 3. 9,000 per month unapata itabidi wa share equally, so huyu mtoto mmoja mwenye ni special case mwenye anataka attention hata iza kupata hiyo attention bila inafaa.
Now, let's do the math. Treatment for multi-drug resistant TB is about repeated hospital visits and good food because the drugs are so hard on the body. So every week, she takes her son to a local clinic for wellness checks and every month to the hospital for monitoring. Each of these times, she's not working. And that is the real bill. Too often, TB is a heavy tax goes up 5 times to 146,000 shillings. In Kenya, even with free drugs, 27% of drug-sensitive TB households spend way more than they can afford. For drug-resistant TB, the number of households was far higher at 86.4%. The World Health Organization has a very specific term for this. It calls it catastrophic costs. That means a household is spending more than 20% of its annual income or expenditure on just one TB episode. But what exactly are families paying for? The WHO's TB economics guidance breaks Kenya's household TB costs into 3 parts: direct medical costs, direct non-medical costs, and indirect costs, which form the largest share at more than half. A further 2021 household study reveals that it's the everyday costs that pile up: transport to clinics, food and nutritional supplements, the time caregivers spend, repeated visits, and the income patients lose while trying to stay healthy.
Even the data showed us we have socioeconomic issues, we have social determinants, which we got from our study, which we need to also consider. We cannot just focus on biomedical interventions alone. We now need to also think of the social determinants of TB, which is a big issue.
Now, let's trace this on a map. This is Kajiado County. It is so vast. Joseph Sankok, the county's TB coordinator, told us that out of the more than 300 health facilities operating in this county, only 80 of them are actually equipped to treat TB. So people have to travel longer distances to find care.
And that is a challenge because it leads to a higher dropout rate. We call it treatment interruption, which is about 8% year in, year out.
When Mary Njogu, the sole breadwinner for her 2 granddaughters, first developed a persistent cough, she didn't have the cash to travel to one of those 80 health facilities. To pay for her very first trip to the hospital, she had to make a trade-off.
Ikabidi niuze kitanda yangu ndio niende hosi, ndio sasa niangaliwe, nikaenda nikapatikana hiyo ugonjwa ndio niko nayo. Mashida ni mingi juu hata chakula kupata ni gumu, niko na hao watoto wanaenda shule.
And even after that, she couldn't afford the transport to the clinic for her 6-month treatment cycle. She relied entirely on a community health promoter to hand-deliver her medication. Which brings us to the second loop of this crisis, the care pathway itself. That 2021 study revealed that while 84% of Kenyans seek formal care immediately, only about 1 in 4 local facilities have actual TB diagnostic capacity. So patients get stuck in a broken loop of repeated visits, referrals, extra transport costs, and more time lost, even before they receive their first pill. For vulnerable families, this doubles their chances of falling further into poverty.
When we come to drug-resistant TB,
And here's the dangerous twist for the entire community. When a family runs out of money for transport or food, they stop taking their medication. And when they stop, the bacteria in their lungs could mutate. A separate study published on the 1st of July 2026 in The Lancet warns that while standard TB is declining globally, drug-resistant TB is stalling. So they could begin transmitting a highly resilient superbug to the community. For years, Kenya's national TB response has been treated as a purely medical problem, but the data proves it is fundamentally an economic one.
TB is an infectious disease. It cannot be told to wait for 30 days or 90 days because the bacteria will keep spreading. And so we have to look at TB as an emergency that needs an emergency sort of response. Number 2, we can no longer continue relegating the health of our citizens to donors. The government has to take the responsibility of the health of the citizens of Kenya as their primary responsibility and ensure that 100% of all aspects of TB response are covered by the government.
And this is the heart of the policy dilemma. TB spreads on biological time, budgets move on political time, and families live in between. According to a WHO analysis, only 9% of Kenya's population is covered by at least one social protection benefit. Meanwhile, the country spends only 1.4% of its GDP on social protection. When TB strikes, vulnerable families feel the sharpest pain. So ending TB isn't just about medicine. Without an economic safety net, this is the real bill. Patients drop off treatment, families absorb impossible costs, and the bacteria gets a chance to mutate and fight back.